Good morning all. In this class we will be dealing regarding viral hepatitis in pregnancy. So the global prevalence of viral hepatitis is very high and seem to be rising over the years. The infection can profoundly affect pregnant women, causing significant maternal and perinatal morbidity and mortality, with some strains much worse than others. Hepatitis A and E, which are transmitted mainly through the fecal oral route, present as acute hepatitis during pregnancy and are responsible for most local epidemic outbreaks. HAV infection remains self-limiting during pregnancy, while HEV has a higher prevalence and causes significant morbidity. So the viral hepatitis is the commonest cause of jaundice in pregnancy in the tropics. Hepatitis is mostly restricted to the ill-nourished mothers living in unhygienic environments in the tropics. It often occurs as an epidemic form. There is also increased incidence of its affection in the pregnant state compared to the non-pregnant one. At present, 6 distinct types are available, that is hepatitis A, B, C, D, E and G. Hepatitis B is DNA virus. So first we will see regarding the hepatitis A. HAV is the most common cause of acute viral hepatitis worldwide. The prevalence varies widely across different countries. The World Health Organization estimates that more than 7,000 people died from hepatitis A in 2016. And it is estimated that HAV contributes to 0.5% of all mortalities related to viral hepatitis. HIV infection has become very rare in high-income countries. However, in the low-income countries, the incidence of fulminant HIV infection is still high, probably aggravated by poor hygienic conditions, availability and uptake of vaccinations, and concomitant malnutrition. So, how it is transmitting? HIV is mainly via the fecal oral route, that is through contaminated water, food, and also through direct contact with the infected persons. But it can also be sexually transmitted through ano-oral route. Acute HIV infection is usually self-limiting and does not lead to chronic disease. Lifelong immunity is acquired with the production of HAV immunoglobulin G, that is IgG, after recovery. Perinatal transmission of HAV is very rare, so considerations during pregnancy should be primarily to support the mother. The mean incubation period is around 4 weeks, that is between range from 2 to 6 weeks. The main symptoms of acute HAV infections are malaise, fatigue, nausea, vomiting and anorexia. And these may overlap with minor ailments of pregnancy, and therefore special attention should be given to the presence of fever, abdominal pain, jaundice, pruritus and dark urine. How we can diagnose this? So the atypical presentation of HAV infection has been reported with relapsed hepatitis and a biphasic elevated serum aminotransferase 4 to 7 weeks apart, and prolonged cholestasis of up to 6 months with acute kidney injury. The detection of HIV in blood and feces is possible to 10 to 12 days following the initial infection. However, the diagnosis is made from the detection of serum HAV immunoglobulin associated frequently with the elevation of serum total bilirubin. Then alkaline phosphatase, alanine aminotransferases and aspartate aminotransferase. Then pregnancy has non-negative impact on the course of HIV infection. Next we will see regarding the maternal risk. However, infection during pregnancy may be associated with a higher risk of maternal complications, and early delivery may be indicated in some cases with a severe liver dysfunction in the 3rd trimester. So in 3rd trimester, if the mother is having severe liver dysfunction, we will conduct a early delivery. Preterm labor occurs in more than 60% of patients, that is around 61.5%, median 34 weeks of gestation, and happens more commonly in women with fever and low serum albumin, that is less than 30 gram per liter. Other possible complications in pregnancy include preterm pre-labor rupture of the membranes, placental abruptions and antepartum hemorrhage. Then vertical transmission of HIV infection is very rare. Intrauterine transmission of HIV, however, could lead to neonatal meconium peritonitis, and prenatal scans should be offered to women with HIV infection to screen for polyhydramnios and fetal ascites. How we can management hepatitis A infection in pregnancy? So mainly supportive include adequate hydration can be given. Appropriate use of antiemetics, antipyretics resolution usually occurs within 2 months, but may rarely progress to fulminant hepatitis with hepatic failure and encephalopathy, and a liver transplant may be indicated. So there is no established antiviral therapy available for hepatitis A virus infection, although preclinical in vitro data suggest that sofosbuvir might have anti-HAV effects. Passive immunoglobulin prophylaxis is available for women who get exposed to HAV during pregnancy, and it is recommended. The prevention of HAV infection entails attention to general hygienic methods, that is drinking clean water and regular washing of hands to avoid fecal-oral transmission of viruses. A potent antenatal HAV vaccine exists and it is safe. It can be given to pregnant women in 2 doses, that is 6 months apart for high-risk population in countries with high or intermediate endemicity of hepatitis A virus and to travelers to these regions. Breastfeeding by women with HAV is relatively safe. Although RNA, anti-HAV, IgG and IgM are detectable in breast milk, breastfeeding is not associated with neonatal infections and should be encouraged. Next, we will see the treatment for hepatitis A virus. There is no specific treatment. It is generally supportive. Then consultation with a hepatologist is ideal. First, we can give rest. The patient should be put to bed rest if necessary by hospitalization. Then isolation. The patient should be kept in isolation. Blood samples are to be collected with gloved hands. Disposable syringe should be used. The excreta is to be disposed carefully. Then in nutrition, diet rich in carbohydrate and adequate protein is to be prescribed. Initially, glucose drink, fruit juice may be given. Dietary fat restriction is not necessary. If the patient cannot tolerate oral feeding, 10% glucose may be given intravenously. Then drugs. To prevent formation of the toxic nitrogenous compound from the bacterial flora of the gut, oral neomycin 1 gram to be given 6 hourly is helpful. Lactulose 15 to 30 ml 3 times daily reduces the colonic ammonia absorption and it acts as an osmotic laxative. Then hepatotoxic drugs should not be used. There is no place for termination of pregnancy. Then prevention of the complications. Hypokalemia, hypoglycemia, hypocalcemia are corrected by regular blood checkup. Hemorrhagic complications are managed by giving blood or fresh frozen plasma. During labor, hepatotoxic drugs should be avoided. To administer vitamin K 5 mg intramuscularly to raise the prothrombin level. Then prophylactic oxytocin is to be given. Hepatologist to be involved. Patient may need ICU management depending on liver function test. So hope you understood regarding hepatitis A virus infection in pregnancy. Next video we will be dealing regarding the hepatitis B virus. Thank you.